Tragically, I lost my son Ben to a fentanyl overdose. It was the hardest thing I had ever had to endure. It's happening across Canada. Fentanyl is wiping out an entire generation of our people. So we started a foundation, Guardians of Recovery, to help people with mental health and addictions who are struggling and not included in society. We've done a great job of including people with disabilities in our society. Now imagine a world where people with mental health and addictions have that same level of inclusion. That's what we're about to do. We are inviting you to take part in one of the most progressive and creative initiatives of our time, building sober living homes for our people to make sure they are cared for and have an opportunity to completely come off substance and live normal, productive lives. Well, hello, everyone, and welcome back to another enlightening episode of Guardians of Recovery. Today, I'm honored to be joined by Dr. Paul Sobey, who is a dedicated addiction medicine physician and also Chief Medical Officer working in Alberta, Canada. Dr. Sobey is a full-time addiction medicine physician and also an adjunct, that word gets me every time, adjunct professor at the Department of Health Sciences at Simon Fraser University. And he's also a clinical instructor at UBC Faculty of Medicine and Department of Family Practice and a former president of the Canadian Society of Addiction Medicine. Phew, lots of accomplishments. Welcome, Dr. Paul Sobey.
Thank you very much. Thank you. Happy to be here.
We're so excited to have you on this show because we're always talking about addiction, always looking for new solutions, and you seem to be right on the leading edge of things. So this is an absolute pleasure for us. How about we start the conversation off where you could tell us, what had you get into this area of addiction, what you specialized in, what you're most passionate about?
Sure. People commonly ask me why am I doing addiction work? My colleagues, when I worked in hospital for 20 years, would ask me, why do you do addiction? And my response would always be because people get better. The work that my colleagues were doing, it was sort of managing chronic disease, and people would get gradually more and more sick and generally succumb to their disease. It's chronic. Mm-hmm. Whereas with addiction, people would achieve recovery. And I find that very inspiring. I'm a guy in long-term recovery, 30 years this year from opiate addiction. And I was a family doctor. I think I burned out of being a family doctor after about 10 years. And I decided to go to the United States. I went to Cleveland and did fellowship work in addiction. And then I did recovery medicine when I got back to Vancouver. I had a really broad spectrum practice, working in jails and in hospital and treatment centers and in the OAT clinic and doing administrative work and seeing consults in my office. And it was recovery medicine. Originally, I'm doing recovery medicine. I'm sharing the same kind of experience I had getting into recovery with people and, fostering, guiding, BSing, cajoling, whatever is required, but generally having a good time doing work. And gradually over time, though, it became addiction medicine as opposed to recovery medicine. And then more recently, I found it more and more difficult to do the kind of work I was doing in British Columbia. And that's why I came out to Alberta, because Alberta is pursuing a recovery-oriented approach. And my business partner and I applied for several contracts here and were successful through a bidding process in getting those contracts. And now I tell people this, I wake up every morning now with the kind of passion I woke up with in my early recovery 30 years ago. So, it's back, and I'm real happy to say that. And I think the sunshine in Alberta's got something to do with it too. Probably.
Could be. But I'm a firm believer. I'm a firm believer that the pains of the past form the purpose of your future. So that all ties in with my theory for sure.
Mm-hmm.
That's
Yeah,
great because not only are you a specialist in recovery medicine, but you also have lived experience, which is such a rare thing and so important in the process because you really get it from every angle.
yeah, true. It brings a certain, I think, cachet, and it brings a certain connection uh, to practice. There are times that I'll disclose to patients my history, but I think a lot more people just pick it up
Mhm.
because it's a common language that people speak.
Right. Yeah. So, in terms of people who are just sort of in the developing stages of addiction, what kind of signs, what are the warning signs that someone might be developing an addiction? And how can early intervention make a difference in that recovery outcome?
Um, it's a really good question because I would see people. Um, I would see people in the emergency department at Royal Columbian Hospital, where I worked for 20 years, and they would have experienced a consequence, generally to alcohol use, and it's generally a motor vehicle accident. Uh,
Yeah.
and I do a history, and I'd look for those kind of telltale signs of loss control, compulsion consequences, that kind of stuff.
Hmm.
I wouldn't be able to tell which 18-year-old is going to go on to be a social drinker, become alcohol dependent, become substance dependent. It was really difficult. I knew cross sectionally that they had a major consequence,
Right.
and that intervention that I did was really focused on stopping further consequences occurring. I think that if you want to predictive factor determine who's going to develop problems, look at the social determinants of health.
Right.
Um, we need to have family history, okay? So there needs to be some genetic component
Yeah.
involved.
Can you shed some light on the role of genetics as well and how that plays into all of this?
Right. So the research tells us that maybe 50% of what causes addiction is genetic.
Okay.
Now, fair enough. But I can't change my genetics.
Right.
So I talk about a story, um, myself and a fellow that I went to school with, who was named Ricky K. And Ricky had a distinctly different trajectory than I did. He and I both started smoking marijuana when we were about 13 years old and drinking when we were about 12 or 13 years old.
Mhm.
But Ricky went to jail when he was 16. I never heard from him again. Um, I was raised by a nuclear family. My dad was a doctor. My mother was a nurse. Ricky was raised in a single mother family. His mother was alcohol dependent. My dad didn't drink. My mother didn't have alcoholism, didn't have drug addiction. There was a family history.
Right.
My parents, I knew what the expectations were from my parents. Ricky never had any expectations. I
Mhm.
I had exposure and access to good health and good mental health services if required. Ricky didn't. Ricky's teeth were rotting by the time he was like 13 years old. So Ricky's access to social determinants of health were distinctly different than what mine were.
Mhm.
And Ricky's trajectory was distinctly different than what
Yeah.
mine was. He was in jail by age 16. I got into recovery when I was age 30. I had access to the highest standard of care available: intervention, comprehensive assessment, treatment, and monitoring afterwards. So, yes, genetics play a role. We can't do anything about genetics,
Right.
but we can certainly change the social determinants of health.
Yeah.
And that's what treatment of addiction and successful treatment of addiction is really all about, is actively intervening on what the social determinants of health are, providing people with access to those social determinants of health. And
Yeah.
over the long term, it takes months and years.
Mhm. And I think our definition of success in all of that, it's in that whole scenario, genetic or not, is that we have architected a system that actually creates those outcomes, no matter what that person's background was, no matter what their genetics is, no matter what their environment is, that like all roads can lead to recovery. And if we actually build recovery cultures, inclusive recovery cultures, it's quite possible that everybody could take that road, or most of the people.
When you look at the literature, especially William White, we know that looking at large epidemiological surveys, the United States does 4 or 6 of them every year, that of people that meet criteria for a severe substance use disorder, something like 58% will achieve a year of sustained abstinent remission. So why only a year? Because that's what we look at. It may be 5, it may be 2, but it's more likely longer. So we know that recovery is the norm. So my approach is not only that recovery should be the expected outcome, it is the expected outcome from my perspective. When I treated a patient with cancer, it's cure. Like the approach is how is cure going to occur? When I treat a patient who has high blood pressure, it's normalization of blood pressure. When I treat a patient with diabetes, it's normal blood sugars. So when I treat people who have addiction, it's the outcome is recovery. That's my expectation. If I don't expect that, I'm not going to get that outcome.
Yeah, precisely. So, I mean, we have so many misconceptions about addiction, which is, partly what you're talking about, that expectation. A lot of people don't expect people to recover. A lot of people brush it off and say it's a choice. Like, what do you think are the most common misconceptions out there, and how can we kind of promote greater understanding and empathy towards individuals in recovery at this time? Because it's sorely lacking.
There's a number of issues. Number one, there's a number of fake narratives. The first false narrative is that addiction is a chronic progressive disease. In the majority of people, it's not chronic, nor is it progressive. It remits. In the majority of people, addiction is actually a disease that achieves remission, if not recovery. Remission and recovery are distinctly different.
Right.
What can we do to help that occur? Well, one thing that I do is as an individual in long-term abstinent recovery, I declare that this is what it looks like. I'm an example of it. I take the approach that everybody should deserve a opportunity to have recovery, and that should be the expected outcome, and that's what I hold people accountable to. So
what is the difference then between remission and recovery?
Remission is primarily a medical term that refers to, conceptually, remission is a deficits-oriented term. Recovery is a strengths-oriented term. So remission is a medical term that refers to there being a lack of signs and symptoms of the disorder. So we would use the DSM in the Diagnostic Statistical Manual of primarily the DSM-5 to talk about remission. So, if you have opiate use disorder and you have no signs or symptoms of the disorder for 3 months, you're in sustained early remission. Okay, so that's remission. But I don't know which one of those 100 people in remission are going to die tomorrow of a fentanyl overdose.
Right.
Okay, recovery is a distinctly different process. It's a strengths-oriented process. It's a non-medical process. You won't find the word recovery in the DSM, although, and I jokingly say the psychiatrists will want to get it in there at some point. It's a disorder that is a process that's characterized by improving wellness, improving functionality, connection, hope, identity, meaning, change in meaning, and further strengths. So distinctly different. One is a wellness-oriented process, and one is a process that is characterized by a lack of deficits.
Right. But aren't we all on the road to recovery in some way, shape, or form?
I don't know. I think that that's probably a bit of a generalization. I think there, if we're going to talk about the term recovery, we're talking about recovery from what?
Hmm.
Recovery is I think that the term recovery can be generalized to a lot of different processes: mental health, addiction, gambling, broken legs, various different processes. But the process of recovery tends to be the same.
Yeah.
It's process. It doesn't occur in an epiphany.
Right.
It's wellness. It's functionality. It's connection. It's
Hmm.
pro-social.
Yeah. I guess that's fundamentally what I mean, is that we're all sort of in a process of always healing something, or, because something always goes out and something's always healing. It's like the body's in a perpetual state of healing.
Right.
Anyway,
But,
that's
but true, because you can use fundamentals of recovery in healing from virtually any process.
yeah, that's right. Yeah. Okay. So for people who are, dealing with things that are as severe as opiate addiction, and they have extreme cravings, and now we're dealing with fentanyl and drugs like that. Can you explain the concept of cravings and addiction, and what are the best sort of strategies in managing or overcoming those intense cravings that people tend not to be able to deal with?
Well, I think that there's sort of two stories to tell here. Story number one is there's a medical approach, and being a physician and doing an opiate agonist therapy clinic practice for 25 years, I've seen people have significant success with opiate replacement therapy, whether that be methadone or oral buprenorphine or injectable buprenorphine.
Hmm.
And the medication that I've seen work the best is, of course, injectable buprenorphine, because it tends to demedicalize the problem. People don't go to the pharmacy. So
Right.
that's one approach. The
Hmm.
other approach is more a social approach. Like I've been in recovery for 30 years. I still get cravings for cigarettes.
Hmm.
When I'm walking down the street and I smell especially Turkish tobacco, it gives me a craving. When
Right.
I'm driving down the street around Christmas and there's lots of advertisements on billboards for whiskey, it gives me cravings. But it's the social context. So when I used to work in residential treatment, people wouldn't complain about craving to me. When
Hmm.
I saw people in a office-based practice, or especially a hospital-based practice, and they were stressed, people are in hospital, they're there for pneumonia or for trauma, they're stressed, and
Hmm.
they're complaining of cravings, and they're asking for more medication. They're
Right.
not in a therapeutic milieu.
Right. Yeah.
So my approach to cravings are like, how can I create a therapeutic milieu
Hmm.
where the individual can take a look at exactly what are they feeling
Right.
and find an alternative method of dealing with that besides using a substance. And the first step in that is connection.
Right.
That's number one, just to sit down and talk and have
Hmm.
a connection and let people know that I understand where they're at, and how to defocus or use, several different DBT, dialectical behavioral therapy methodologies to help people address what is a really normal facet of addiction, which is craving.
Right. Right. Well, what about someone who has, like, in terms of they're physically altering their brain, they don't have cause and effect. People who couldn't make a decision, life-saving decision if they tried, because of things like anosognosia or bipolar or schizophrenia, or people just don't have capacity at all. Um, can you sort of take us through that, and what is the solution to that?
Well, that's a more complex problem.
Yeah.
There are lots of people living on the streets. The downtown east side of Vancouver is replete
Yeah.
with the individuals that you're talking about. So,
Hmm.
the approach is, I think one approach is how to stop people getting there. That's number one. And then for people that are there, what can be offered? What are the humane approaches? So, how to stop people getting there? Number one, my approach is demand reduction as opposed to a supply side approach. So I use an economic analogy. A
What does that mean? I'm confused.
supply side versus demand reduction. Okay,
Okay.
so in COVID, world governments expanded the money supply by about 40%.
Hmm.
What happened? Inflation.
Right.
Well, how do you reduce demand? You got to crank up interest rates,
Right.
right? So that's a supply demand reduction analogy.
Yeah.
Our current approach to the drug problem is a supply side approach.
Hmm.
We're increasing the supply of substances, BC, especially in some areas in Ontario, in an attempt to provide a safe supply or in an attempt to provide a supply that overwhelms the street supply.
Hmm.
So in essence, it's a war on drugs.
Right.
The original war on drugs under President Nixon was interdiction, where they would go to foreign countries, try to stop drug production, try to stop drugs coming into the country. It was interdiction related. Well, this is the same thing from my perspective. It's an analogy to a war on drugs because the focus is on the supply of the drug,
Right.
right? So it's increasing the supply in this circumstance as opposed to trying to decrease the supply. Supply side approaches generally don't work very well. As we've seen, anytime you increase the supply of drugs, and I'll argue people until they're blue in the face, it'll increase demand,
Right.
right? You increase the money supply, people got money, they don't squirrel it away, they spend it.
Right.
And that drives up the price of goods.
Hmm.
So if we increase the supply of drugs, what happens is people use them, there's
Hmm.
greater access, it's diverted, and the likelihood of developing the cases of opiate use disorder or other drugs goes up. The
Yeah.
alternative side is demand reduction.
Hmm.
So you
It's
reduce, you
a very
reduce.
powerful analogy. Yeah.
Yeah,
Thank you.
yeah.
That was succinct. Thank you. Okay.
I,
Continue.
I
Sorry.
have to give credit for the analogy to my colleague, Dr. Julian Summers.
That's
Demand reduction is the Portuguese approach. So
hmm
Portugal had the highest overdose death rates in the European Union in 98. And then by 2004, 2006, they had the lowest. And what they did is they reduced demand for substances by increasing treatment.
right.
So they built out about 26 therapeutic communities between 98 and July 2001, when they decriminalized drugs.
Hmm.
And with decriminalization, there was also, if you're caught with a small amount of drugs, you're arrested, you go in front of a dissuasion commission the next day, and you're offered either a criminal approach, you go to jail, or a treatment approach. And people chose treatment because people generally will choose treatment.
Right.
And so what dissuasion did, decriminalization and dissuasion commissions, is it drove people into treatment.
Right.
So they reduced demand for drugs by increasing treatment. So you
Hmm.
got a supply side where you increase the supply of drugs or attempt to interdict on the supply of drugs, and a demand side reduction where you reduce demand for drugs by improving access to treatment. This is the Alberta model, so to say.
Right. Makes
So
perfect sense.
that's how you reduce the likelihood of the essentially people that are unable to consent to treatment
Yeah.
occurring.
Right. Yeah, makes perfect sense. With you all the way on that one. And I think that's exactly it. We need more help with a treatment approach. Like here in Newfoundland, we have a lot of what they call low barrier shelters. Everybody's still continuing to use, and consequently, those shelters are very dangerous.
Mm.
Everybody's using. First of all, you're putting all kinds of people together who are on drugs, and 9 people to a room or in these shelters, and on top of that, it's you can use drugs on the premises, or you can continue to be in drug use, and there's no road to recovery as such. There's no stipulation. Like, that's a huge misconception about Portugal. Everybody just thinks, oh, Portugal legalized all drugs and it worked out great. But no, they actually built an infrastructure that was very systematically focused on all roads leading to treatment. And that's exactly what's happening.
Yeah. So you're describing a very supply-oriented approach in the shelters in Newfoundland.
Yeah.
Yeah. And the narratives around Portugal, of course, are muchly incorrect. And that's part the Portuguese, because they didn't collect good data at that time. They only looked at overdose death rates and Hep C and HIV cases primarily, as opposed to much more granular data.
Mm-hmm.
And the narrative around Portugal legalizing drugs is, of course, absolutely incorrect. They didn't legalize drugs; they decriminalized, and there's a distinct difference between decriminalization and legalization.
Right. Yeah, exactly. Okay, well, that's so interesting. So in terms of like the safe supply as such, what do you think is appropriate when it comes to safe supply? Should we be giving people crack pipes? Should we be giving them, all of the paraphernalia to continue to use drugs? What do you think is appropriate and inappropriate when it comes to safe supply?
Yeah, so you're talking about harm reduction approaches, and I'm an advocate for harm reduction. Number one.
Mm-hmm.
I've done harm reduction work for the majority of my career. Ever since I've been a doctor, I've done harm reduction. I never expected a insulin-dependent diabetic to achieve perfect blood sugars right off the bat. It was always a process over months and even years of motivational interviewing, cajoling, being that patient's physician before they achieved the best outcome that they're going to be able to achieve.
Mm-hmm.
So I'm an advocate for harm reduction in the treatment of addiction.
Mm-hmm.
I meet people where they're at.
Right.
I don't leave them there.
Right. That's the difference, I think, is that we're providing people with all of these tools to continue and leaving them there. And we have an epidemic of overdose deaths occurring.
So my approach is what's appropriate for harm reduction? Well, demonstrate that harms are being reduced.
Mm-hmm.
There need the obligation is on the onus is on the individual that is providing the intervention to demonstrate that harms are being reduced. If harms are not being reduced and the individual is remaining where they're at in harm, that's called harm production.
Yeah, precisely. And that's
conversely, the onus is also on the recovery-oriented approach to demonstrate that those outcomes are occurring.
Mm-hmm. Yeah, and all those open-ended scenarios are leading to, like, that's what led to the death of my son. He was in drugged-in shelters, and everybody was using drugs, and his drug of choice was weed. And then he got into all kinds of opioids, and he was in one shelter where everybody was injecting, and he ended up with like 50 injections in his legs, and it wasn't long after that they put him on Suboxone, coupled with every other kind of drug you could take. And it was 2 months before his brain was just so scrambled. Like, he had no cause and effect whatsoever. And that's the part that I kind of think about is when someone's brain is actually hijacked and they don't have any resources around them. The term capacity, how does one know? Like, I like what you said, the onus is on the harm reduction people to prove that that harm is being reduced, or that addiction is that person is starting to recover as a result of these things. That should be the scenario for our shelters as well. But when someone is actually in the throes of addiction and their brain is shut down and they can't make a decision for themselves, that's the part that I feel is causing, most of the people I feel that are homeless and on the streets, and you ask them, if they're doing okay, and they say they're perfectly fine. I had a brother with bipolar and schizophrenia. My oldest brother, he eventually died. And I would always ask him, how are you doing? And his life could be falling down around him. He could be burning a hole through his fingers with cigarettes, and he did not have the capacity to even know he was sick.
Mm-hmm.
So I see a lot of that going on the streets. I see a lot of people who have, skin falling off and no capacity. That's the place where I feel that we really need to help people, because they actually don't have a capacity.
Yeah. So what you're talking about, we use various different words and frameworks to conceptualize what is a lack of insight. And capacity is really medical or possibly a legal term that speaks to a certain point in a loss of insight, where the individual can then be said to not be able to make certain classes of decisions for themselves. So this is a complex issue, and treating people in hospital for 20 years, I've certainly used the Mental Health Act on probably 1,000 occasions to certify an individual under the Mental Health Act to hold the individual in hospital, because they were generally, in 99% of cases, a danger to themselves, and in 1% of cases, a danger to other people. And what I found really interesting was that by 48 hours, so in British Columbia, you can certify an individual with a single signature for 48 hours. And that gives the physician the right to hold the individual in a hospital, treat the psychiatric disorder, not treat the other medical disorders, but treat the psychiatric disorder. And what I was really interested in seeing is that the majority of those individuals achieved insight to the point that I could do an intervention within that 48-hour period of time, commonly within 24 hours.
That makes perfect sense. That, like, in any psychiatric intervention would be helpful. But here in Newfoundland, people overdose, they go to hospital, and then they're let out right away, and there's no psychiatric assessment at all.
Yeah, and I'm not a psychiatrist. I'm a family doctor by background, and psychiatry would also generally be involved with the case. But the issue is that with the Mental Health Act, the means by which it is determined whether the individual is certifiable is doesn't really take into account it's acute danger. So I know an individual that has, say, been Narcaned on multiple different occasions is at very high risk to be Narcaned again, overdose and Narcaned again. I know that individual has experienced what's called an hypoxic brain injury.
Right.
They've experienced a brain injury that is secondary to the use or lack of oxygen.
Yeah.
Of overdoses that cause death, possibly 4 to 10-fold that number experience hypoxic brain injuries. And what that results in is clear loss of insight, clear inability to not use drugs to make rational or higher order decisions. But the Mental Health Act doesn't have the sensitivity to detect that.
Right.
Now, is that really important? Well, I believe, based on the Portuguese experience, that if treatment is expanded adequately, the vast majority of those people will choose treatment.
Right. Well, in the case of my son, Ben, he overdosed the day before. And then, as you said, he was just completely not at all in any state of mind and didn't have capacity because I saw him. I went to the hospital and he just like woke up and like in a flailing, fury, just left the hospital. And, you could just tell he wasn't thinking straight. And within 24 hours, less than 24 hours, he was dead.
Yeah,
And
I'm sorry to hear that. But
yeah.
Alberta is experimenting with this, or moving toward, not experimenting, but moving toward creating legislation under the Compassionate Intervention Act to address those people that are that ill.
Yeah. Let's talk about some of the positive things that Alberta is doing. Tell us, what the framework is and why it's succeeding.
Well, I can certainly tell you about the work we're up to out here, and
Yeah.
comment to some degree on other programs. We're my company, Raw Solutions Group, are uniquely involved in the correctional sphere. We know that approximately 70 or 80% of people that are incarcerated have a severe substance use disorder
Mm-hmm.
and have had lack of access to the social determinants of health.
Yeah.
We house people with addiction, lack of access to social determinants of health, and especially Indigenous ethnicity or minority ethnicity in jails.
Yeah.
And so this is a captive population, and what we're doing is we're creating what are called therapeutic communities in jails or therapeutic living units. So we've stood up 3 of them, and we've got another one to be stood up in May. We're
Okay.
also creating something called transitional services, which are a basket of services that people in remand centers will be offered to reduce the likelihood of criminal and medical recidivism, including referral to TLUs and community recovery centers. The government of Alberta is building 11 therapeutic communities. So if you think of Portugal's population was 10 million and they built 26 of them,
Mm-hmm.
Alberta is building 11 for a population of 4 million. So that's about the same number of beds.
Right.
There's
Yeah.
only 2 stood up now. The third one will be out at Gunn, and it's going to be called Lakeview. We're standing that one up. And then Calgary, Edmonton, Grand Prairie, and 5 Indigenous therapeutic communities.
Wonderful.
And then, go ahead.
I was going to say, can you come to Newfoundland? We need you over here.
Yeah, well, we're more than happy to work 8 days a week to expand this model. I like I said early in the interview, I'm just full of passion on a daily basis. I look at this as an opportunity.
Yeah.
An opportunity to do good work.
Yes.
We're also doing a lot. We're also standing up what's called the Recovery Training Institute to train people in high quality, primarily webinar-based training. And then people will come to Lakeview or the therapeutic living units to do practicums. And then we're training recovery coaches. And there's a whole bunch of other programs here in Alberta, notably the virtual opiate dependency program, which is led by a really capable fellow, Dr. Nathaniel Day, and has seen, I think that the virtual opiate dependency program, there are more people that are receiving OAT in Alberta than the majority of other jurisdictions in North America, because you can access OAT in 20 minutes in Alberta.
Mm-hmm.
I see people in my work in jails where I talk to them and what happened. I was in the back of a police cruiser. I was in withdrawal. I called the VODP. The Suboxone came to the jail. I was initiated there within a couple of hours.
Wow. That's amazing. Because, as people are, taking drugs and coming off drugs, they have all kinds of wild and wonderful reactions. That's for sure.
Mm-hmm.
Yeah. Interesting. I've got a bunch of comments here that people are watching and commenting as we go. I'm going to see what they have to say. They're talking to you.
Okay, very good.
Charmaine says, hi. Geraldine says, interesting conversation. Thanks for sharing. Connection is so incredibly important. Going back to your point of earlier. That's the answer. We need more help with treatment approach. Indeed, we do. Totally against safe drugs. Get real feed it to them free. That's nuts. Detox and rehab education. That's someone pro detox. I look to the policies and upcoming legislation in Alberta as a model for addictions recovery in the province of Newfoundland and worldwide. I applaud you moving to focus your work in a province that prioritizes access to recovery. Me too. Amazing programs. Excellent. I want to learn all about them, see what we can do about getting them here in Newfoundland. I'm absolutely passionate about transforming the environment in Newfoundland and Labrador because Guardians of Recovery is just full of parents and family members and people in recovery who are desperate for help. Like, we can't even get people into detox here. We have 3 beds available, and even though there's 19 beds there, and a lineup of people trying to get in. And then once they're out of detox, they can't get into recovery. It's brutal what's happening here.
Yeah, but I really think it's organization. This is grassroots movement, and that's what I like about recovery. Is it's not top down. It's grassroots. And community based. So it's organizations like yourself that are really Mother Start recovery organizations.
Yes.
Right. That are pro recovery, that are advocating for treatment, for detox, for better care, advocating for recovery as the standard of care.
Yeah.
Right. Not as something that somebody might achieve, but it's a rare finding. We wouldn't, like, if our sons and daughters were dying of cancer, we wouldn't be advocating for palliative care,
right,
for what is a potentially curable disorder, and in fact, in the majority of cases, achieves remission. This is ludicrous.
Yeah.
So my compliments are to you, Tina, for advocating for recovery being the standard of care and advocating to government to create services that achieve that outcome.
Yeah, I'm advocating for government. They're not listening, though. We just had another low barrier shelter approved for another, I think, $21 million going into a low barrier shelter. And I'm just scratching my head saying all these millions of dollars going into low barrier shelters with the continuation of harm reduction, safe supply without anyone going to recovery. It's just so infuriating. We definitely have to get a lot more professionals down here and speak to our government to get them to understand. But that's why I'm doing this podcast, because you can be sure right after this show, I'll be sending it to all of them. So that's the thing. Okay. When it comes to the future of emerging treatments and therapies, give us something to be hopeful about. We understand that recovery obviously is the road, but is there any new technologies, any new innovation, any sort of, I was reading some things that people, were finding some genetic solutions, maybe seeing that like genetic vaccines for recovery. I don't know. It's pretty out there. Nothing conclusive yet, but do you see anything exciting on the horizon?
Yes. I don't want to burst your. I don't want to. Hold on a second. I'm sorry. I don't want to burst your balloon, but the most exciting thing that I see in recovery these days is a transition from a model that focuses on addiction as a medical disorder that exists in one's brain to a disorder that is a consequence of and best treated by addressing social determinants of health. So let me tell you this story about the National Institutes of Drug Addiction and the National Institute of Alcoholism and Alcohol Abuse. And people working for those organizations, which have multi-billion-dollar budgets, won't be happy about me saying this. So NIDA does the majority, like I'm not sure, but it's a very large percentage of all the neuroimaging that's done in addiction in the world. And in the early 90s, Alan Leshner, who was the head of NIDA, declared the 1990s the decade of the brain because neuroimaging discovered where in the brain addiction was.
Yes.
And it was only around the corner that neurotargets were going to be found and new medications were going to come out and we would have this thing licked.
Right.
Well, NIDA has invented a sum total of 0 molecules that have come to market. 0.
Right. Didn't happen.
Buprenorphine or Suboxone was on the market in 1989. Methadone was 1964. Pardon me, in America, or 1959 in Canada. There have been no really efficacious medications oriented. And so 42,000 people have died in the last 8 years.
Yeah.
From not I don't want to call it the opiate epidemic, it's the poly-drug epidemic. Okay? It's a poly-drug epidemic. And we have very effective drugs for opiate use disorders, specifically buprenorphine and methadone, especially injectable buprenorphine. But there is no drug that's effective for methamphetamine addiction, cocaine addiction, marijuana addiction. Alcohol is there are 3 drugs that can be used for alcohol addiction, but none of these drugs by themselves are terribly effective. They all have to be part of a comprehensive program. And so the shift away from addiction as a brain disease and the focus on finding neuro targets that we're gonna have a cure for in the short term, it excites me because in my recovery, I didn't take any drugs. I didn't take any medications. I got really good treatment.
Yeah.
And the people that I went to treatment with, all the doctors the 2 other doctors that I went to treatment with, and the literally hundreds of doctors and nurses and paramedics and other healthcare professionals I've treated over my career, the vast majority of them achieved recovery. And none of them, like literally, or not none, but extremely few received any medication for addiction. So I'm excited about the shift toward demand reduction.
Yeah.
That's where the answer is right now.
Yeah.
Those are the targets we can change right now.
Yeah.
And I'm not going to give up what I can do here and now for, a potential big gain in the future.
Yeah. Makes all sense in the world.
You got a bird in the hand.
Right, exactly. And that's my definition of harm reduction right there. Precisely. Interesting. So before I let you go, I'm thinking about building, I am going to be creating sober living homes, probably similar to your therapeutic living units. What's it like in your therapeutic living units? What can you give us, like, what it would be like for someone to attend? What's a day in the life of it? How's it set up? How do you set them up to succeed?
Really busy.
Yeah, very focused, busy.
Get going at about 7 in the morning, get done at 10 at night. So therapeutic community isn't new. It's been around in its current form for probably about 60 years, and in a looser form for more than 100 years. If you stick to the 14 basic components of what a therapeutic community is, it'll occur. So some of your people that are listening may have been to treatment, and sometimes in treatment, or a lot of the time in treatment, what'll happen is you'll have a really good group in treatment, and it'll be clicking, and everybody will be connecting, and feeling like they're getting better and moving forward, and there's a shared understanding. That's what therapeutic community does. It's a framework that creates intense social capital. And then you look at And there's various different ways that occurs. It creates a source of belonging. It creates a place where a person can alter their narrative redevelopment. It creates recovery capital, etc. But I look at therapeutic community as a basic framework. And then you got to look at, okay, so who are we treating in that therapeutic community? And in jails, that is a population that has severe substance use disorders, has significant emotional dysregulation, a lack of emotional insight, criminal addictive thinking, culmination or clustering of signs, symptoms, and experiences in life. And so you layer on treatment modalities that are effective in treating those. We use a lot of CBT and DBT and motivational interviewing. It's all group oriented. It's not one-on-one. One thing that I find is really important in the therapeutic community is we have fun. We have fun together, because a lot of the men and women that come into the therapeutic community, they've never really had fun. They don't know how to have fun. So you have to teach people how to have fun as a group. Like, how do you do games night? And have everybody engaged in it? Because when we initially started doing this, we would do games night and people would be confused about, there'd be 2 or 3 of the group of 20 that were familiar with it and could engage in it, but 17 or 16 of them were confused by the experience. So therapeutic community is busy, it's long-term. People need to be in a therapeutic community for at least 4 months and preferably 12 months.
That's a good idea. I love that too, because that gives
they didn't get here in a day. They don't change in a day.
Yeah.
And look at it like a framework that is very busy. It's high dose, right? It's high dose treatment. It's intense treatment. People should be exhausted by the end of the day.
Yeah. Yeah. And focused on all the things that they're up to. And do they have a chance in that time frame? Like, do they actually think about working, or do they just focus on healing themselves?
Well, in the therapeutic living unit, in jail, most of the individuals that we're seeing there on sentence or remand are going to be there for in and around 4 months. So our primary discharge objective is to go to one of the recovery communities where social reintegration in the form of occupational and vocational opportunities are taken up.
Right.
So the primary focus of therapeutic living units, which are in jails, is primarily social rehabilitation.
Right. Gotcha. Interesting. So interesting.
When you look at the community-based therapeutic communities, there's a huge component of occupational rehabilitation, like all kinds of programs that are relevant. Like small engine repair is not a relevant occupational program anymore because there are no small engines; they're all electric, right? But framing is, agricultural is.
Right.
And so those are the cottage industries are. And if you look at European therapeutic communities, they primarily focus on getting people trained in occupations that are local. So it would be things like the oil industry, the uranium industry, potentially, agriculture, city, building trades.
Yeah, we have sober or inclusive recovery cities starting to pop up now, all based on this model of inclusion and community first and foremost, and connection within your community, which I think is so cool. Because I envision a future where we have like sober living work camps in the energy industry, and sober living villages, and that way people can find their space or their home or their place or whatever. I just think that'd be so cool. I'd like to go to a sober bar. I'd like to go to a sober cafe.
Yeah, you're speaking my language, especially with the recovery informed workplace. This is a passion of mine, having done occupational addiction medicine for the last 10 years of my career in British Columbia. This is an area I want to really focus on in the next couple of years, is creating large scale programs to scale up recovery-informed workplaces. And you talk about inclusive recovery cities. This is David Best's work. Really
Yeah.
interesting work. We speak a lot about ROSC, the recovery-oriented system of care.
Mm-hmm.
But when you look at the literature around it, there's not a lot of literature in the last decade on ROSC. But what there is an evolving literature on inclusive recovery cities.
Yeah.
And the reason for it, and I interviewed David Best about this for 2 days in Ireland in February. It's interesting because recovery capital tends to flow from the community to the person more than it flows from the person to the community, i.e., it takes a village to raise a man, or broken windows are good analogies to this phenomenon. So, that being so, we need to be able to assess the recovery capital of a community, of which there's evolving instruments, and we need to be able to grow a community's recovery capital so that people will become healthy. It'll flow from the community to the person.
Yeah.
So these are core kind of concepts that we need to know if we're going to be successful in in the recovery movement.
Yeah, exactly. Yeah, we had David Best on the show too a couple of weeks back. He's fascinating, and I love all that work. I must talk to you more about this after the show, and whenever you have a chance, because I really do think that is the future. We're starting to build a model here for that, and starting to introduce it into our energy industry companies, and it can become a way of life.
Mm-hmm.
Yeah. For sure. Awesome. Thank you so much. You've answered so many questions. You're an absolute wealth of knowledge. Is there anything else you'd like to say before we go?
Well, thank you very much for having me. I'm always happy to talk about recovery and the work we're doing, and I see it as just an opportunity to do good work, and I'm happy that I'm here.
Yeah. Thank you so much, Dr. Sobey, for sharing your insights and your expertise. And to all of our listeners, thank you for joining us on the Guardians of Recovery podcast. Stay tuned for more chats like this, ones that are going to pave the way for a new recovery future. So that's it for today. Until next time, take care and stay well.
Okay. Bye-bye.